Good afternoon and welcome to Consensus and Controversy, where clinical investigators provide their perspective on the current and future management of endometrial cancer. I'm Dr. Shannon Westin, and I'll be moderating the meeting this afternoon, and thank you all so much for coming. So first, let's meet our faculty for today. First, all the way on my right, Dr. Nicoletta Colombo from the University of Milan. Welcome. Dr. Brian Slomovitz, who is at the Florida International University. Welcome, Brian. And Dr. Matthew Powell from Washington University School of Medicine. And I'm Shannon Westin, and I'm at the University of Texas MD Anderson Cancer Center. These are our disclosures. We'll pop through those quickly, but feel free to review anytime. This program will include discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. So let's get started. This is where we're heading this afternoon. We're going to start out with Professor Colombo discussing the upfront treatment of advanced endometrial cancer. Then I'll talk about novel investigational strategies for newly diagnosed endometrial cancer. We'll kick it over to Dr. Slomovitz, who will talk about current options for relapsed and refractory endometrial cancer, and then finish with Dr. Powell addressing the role of HER2-targeted therapy. In order to make this meeting more relevant to participants, a survey of key clinical questions was conducted, and these results will be shared and discussed during the program. Dr. Love also had the opportunity to interview Drs. Flor Bacchus and Ritu Salani, two non-faculty survey participants, on their perspectives on a number of key clinical issues. Video excerpts from these interviews will be featured through today's program as well. So first, we're going to move forward with current approaches to first-line therapy for advanced endometrial cancer, and I'd like to bring, we're going to start with the videos. Oh. Apologize. So first, the questions that were asked to the consulting faculty were perspectives on first-line treatment landscape, response to dostarlimab with chemotherapy in a p53 wild-type subgroup of patients.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and special thanks to our consulting faculty for working with me over the past couple of weeks to develop some interesting questions for Dr. Westin and the faculty on the stage to consider today, beginning with perhaps the most important issue in the field, first-line therapy of metastatic disease.
Where we are now in the current landscape for mismatch repair deficient, and we've seen the results from the trials with immunotherapy, with chemotherapy, how are you going to use this data and have this control arm of carboplatin paclitaxel alone and to draw any conclusions of what we should do or if pembrolizumab by itself is safe or effective enough? When we're thinking about overall survival benefit and balancing that with the toxicity also that we can see with long-term use of immunotherapy, and especially if we're thinking about using immunotherapy for 3 years, as was done on the RUBY trial, what is the benefit you'd like to see, or what are some hazard ratios? How big does the difference need to be for you to start using immunotherapy or dostarlimab, especially in the mismatch repair proficient patients?
How about patients with MMR tumors and the new RUBY data looking at p53?
The interesting thing to me is the subgroup analysis. So this was presented later, but the p53 mutation population did seem to have a signal that was almost as, if not equal to, the dMMR population with the addition of immunotherapy to the chemotherapy. And I'm wondering, subgroup analysis can also be flawed, where it's not a statistical endpoint. But what are your thoughts on the p53 mutation group?
Okay, so we've got the questions here, just so you guys didn't have to memorize them. So we'll start with Dr. Bacchus's first question, the preferred first-line therapy for metastatic MSI-high or dMMR endometrial cancer. And do you differ your approach based on younger patient, no comorbidities? Does the PD-L1 status matter? I'd love to do like a quick round robin. Do we feel like we all have pretty much agreement? Dr. Colombo, do you want to start?
Yeah. The preferred regimen is for sure carboplatin paclitaxel plus ICI. In Europe, we have dostarlimab available, not pembro, but that would be, and no different approach according to PD-L1.
Yeah. Any difference of opinion here? So chemotherapy with an immune checkpoint inhibitor that's approved?
No, I agree. It's so important. The impact here is, the same or even greater than using PARPs for BRCA-positive patients.
Yeah.
I mean, the hazard ratios are so low, so you really have to consider checkpoint inhibition in those patients with DMR tumors.
Right.
And as far as age, with no comorbidities, I would treat them the same way.
And is anybody using PD-L1 status yet to guide therapy use?
I do not.
Yeah, especially not in the setting of MSI high, where I feel like we have very clear data. Dr. Powell, do you do anything different? What's your preferred anti-PD-1 or PD-L1? We do have friends in the audience, so.
Yeah, I don't think there's a major difference. I think if they're eligible for either the 018 trial or Ruby, very reasonable. I think what you got at a little bit is there's somebody with significant morbidity, what would I do?
Yeah.
And I might choose a single agent checkpoint or be quick to stop or hold chemotherapy in those patients that just aren't tolerating, because I think that that checkpoint is so important for that patient. We'd hate to have to forego all therapy because of their comorbidities.
Yeah, Dr. Slomovitz?
Yeah, no, and Matt alluded to this. The important really question is going to be, do we need chemotherapy for these patients? And as you know, there's the C93 and the Dominica trial,
Right.
both addressing this, and we're looking forward to those results to see if we can eliminate chemo in those patients.
Yeah, we'll get some answers from some prospective trials there, but I agree with you, Dr. Powell, in the patient population who maybe isn't as fit for chemo, sometimes utilizing a single agent off protocol is really nice. What about mismatch repair proficient or microsatellite stable? I'll start on this end with you, Dr. Powell. What do you do in that setting?
So I think one of the things we've learned is that kind of all patients benefit, and the magnitude of benefit's different.
That's right.
When you look at that DMMR benefit, it's so staggering. You get so excited, and then you get less impressed with the PMMR, but it's still there, up to a 20% benefit in that population. Or if you look at the P53 mutated status, even greater, is pointed out in the video. So I think that typically would be using it for all patients.
I've definitely been talking to all my patients about it. Were you expecting that, Dr. Slomovitz, that the P53 mutant would benefit so much more from immunotherapy, or was that surprising to you?
Yeah, I mean, I'd be cautious in saying benefit in so much more. It's a subgroup of a subgroup analysis there. But there does appear to be benefit. It needs to be further looked at. One of the things I'm doing, I discussed this in another group earlier, one of the things I'm doing in practice in the P53 mutated patients is not only thinking what I'm giving them first line, but what next.
Yeah.
With that in mind, I'm actually still using, I'm using carboplatin, paclitaxel, bevacizumab in the first line, knowing that I can save lenvatinib, pembrolizumab in the second line, where if I didn't do that, I really don't have a lot of good second line options.
Okay. All right. Very, very compelling. All right, let's go to the next video. This is around the potential use of immunotherapy combined with chemo in the adjuvant setting, management of endometrial cancer with a POLE mutation.
Two other issues for our faculty on the stage to comment on. First, the increasing recognition of the very uncommon POLE mutant tumors that require a fundamentally different approach to treatment, and hopefully soon to report adjuvant immunotherapy trials. And if these data resemble what's been seen in non-small cell cancer of the lung, renal cell cancer, and urothelial bladder cancer, gynecologic oncologists are going to have a major challenge dealing with a new clinical scenario, adjuvant therapy, where some of the patients are already cured but are going to be exposed to these therapies.
We're looking forward to seeing the results of those trials in the adjuvant setting. Does it need to be overall survival? What side effects are worth it? And which populations are you going to use it for? Would you consider using this right now? If so, would you consider it in the mismatch repair deficient population also, or have you already adopted this for the mismatch repair proficient population? And how long of follow-up data should we see before we really get some firm conclusions? I would love to ask the panel, should we be treating, based on the data that we have from in the recurrent setting where the addition of IO to chemotherapy seems to be so beneficial, should we be doing that already in the upfront, no measurable disease adjuvant setting? Or should we wait for actual data coming out? In that patient who has, say, a stage 1B grade 3 or a stage 2 endometrial cancer, meets the high intermediate risk criteria, but has a POLE mutation, what is your management for this? Are we ready to de-escalate and not give these patients treatment? And how would that differ for a patient who has a completely resected stage 3C endometrial cancer with one positive node? Is this a patient that you take POLE into account for how you recommend adjuvant therapy?
Okay, so lots of questions. It looks like Dr. Colombo wants to tackle the first one.
Yeah, I want to, discuss the poly because we are just rediscussing and the guidelines, the ESTRO guidelines, and there is this huge amount, thousands of patients, including in PORTEC, in the PORTEC studies, and all patients with poly, none of them had never a relapse. So for me, and we are doing already in our institute, we are not treating 1B grade 3 poly mutated. She will not get any adjuvant treatment. Having said that, last week I had 2 patients poly with relapse. But of course, you have to follow them closely. But yeah, this is what it is.
Any difference of opinion, Dr. Slomovitz or Powell? What do you think about de-escalating in poly?
Yeah, only to highlight that hopefully we'll have a trial available for these patients soon with, here in the US, it'll be called GY032, de-escalating for those poly patients. We're not actually opening the stage 3 cohort here in the US, but the stage 1 and 2, where they get de-escalation of therapy and basically observed. One of the things to point out is we see poly in the uterus, maybe 3 to 7% of the time, but we rarely see it outside the uterus in that recurrent metastatic disease. Right. In Ruby, it was 1.25%.
Yeah.
So it's worth looking for, but we don't see it very often having to need systemic therapy.
Okay.
Yeah.
And I think these, go ahead, please.
I was going to say a more general comment is really identifying these patients with the poly mutations.
Yeah.
It's not part of our universal testing. A lot of times it's a send out. So while a lot of the other testing is done in-house, we don't know who they are.
Yeah, I think a simplified poly test is definitely very much needed. And I think we covered those other 2 questions pretty well. I think this group is open to considering this in the adjuvant setting and especially moving it to an all IO therapy. So we'll move on. This was a survey, just as we mentioned before. We had a survey of our experts, both on this panel and those that asked questions. And I think just looking at what our usual treatment is of certain situations. So here you can see first-line therapy for MSS, metastatic endometrial cancer, and do you prefer a specific PD-1, PD-L1? And I think you can see here there's not a true consensus, but the majority of people are considering chemo with one of the approved or compendium listed immune checkpoint inhibitors, but it's not universal yet. And I think there's many of us that are waiting for overall survival, waiting to see a little bit more of an impact there. Now here is very much agreed upon. So this is metastatic MSI high, and I think just like you saw in our panel discussion, there's a pretty nice consensus here around utilizing immune checkpoint inhibition for this important population. You can see some people sticking purely to the FDA label with dostarlimab. You can see others kind of considering both, although we hope that all will be listed soon. Now, this is, I think, a little bit more interesting. So this is adjuvant therapy. So this is for a patient that has a hysterectomy, localized endometrial cancer, and 2 positive lymph nodes. What would you do? And here it's a little bit more all over the place. There's definitely a consensus to use chemo. We have radiotherapy being added, and then we do have a few of our faculty members considering utilizing immune checkpoint. Any thoughts about that panel? Dr. Slomovitz, you're one of them.
Yeah, the other, just remember, and Matt, you could maybe clarify this. In Ruby, technically, some of the patients are adjuvantly treated. I think we're allowed to include some of the 3C2s, even resected or not. So there is some data there suggesting that in the adjuvant therapy, super high risk, the disease is already there, that there may be a role there. And I think radiation is not a bad option here. I think, if to start, one of the other issues about selections here, we could choose what our favor is, but a lot of times in the U.S., payers are going to help choose for us which one, so it'll play out that way.
Okay, and then the last one, adjuvant. This is a patient that had hysterectomy and then was found to have 1 isolated lung metastasis that is actually resected as well. Similar results, I think, to what we saw before. You see chemotherapy, and then you see the addition of immune checkpoint for some of our experts here. And I think most of us, even though a lung metastasis is resected, would still consider this patient as stage 4, and there's likely disease in places that we can't see or resect, and would want to do pretty aggressive adjuvant therapy here. So with that, I'm going to turn this over to Dr. Colombo, who's going to take us through the data on first-line therapy for advanced endometrial cancer. Thank you so much for being here.
Thank you very much, Shannon. So I have to overview the current approaches to first-line therapy for advanced endometrial cancer. As you know, endometrial cancer is still still represent a burden worldwide, with more than 400,000 new cases and more than 97,000 deaths. And it is the only gynecological cancer with rising incidence and mortality, particularly, I think, in this country. In the last year, we learned that it's important to classify endometrial cancer according to this molecular classification, which has now been incorporated into the major guidelines and even in the FIGO staging system 2023. And this is important because it gives you important prognostic information, is important for risk categorization, is predictive of benefit of treatment, and also important for genetic screening for families with Lynch syndromes. And so according to this classification, the endometrial cancer can be classified as poly or mismatch repair deficient, and if it's not poly and not mismatch repair, then it can be P53 mutants or P53 wild type. And inside this P53 wild type, it's important to distinguish the ER positive and the ER negative population. Why this is important? Because we know that the polymutated and the DMMR are those tumors which will respond much better to immunotherapy. And in fact, how many patients with endometrial cancer will have a DMMR tumor? You see different trials report different percentage of DMMR, but overall it's depending if it's a newly diagnosed, recurrent disease, advanced, and so on. But overall, we may consider about 30% of patients with endometrial cancer will have a DMMR tumor. Remember, however, that very few of them will have a Lynch syndrome, so the germline mutation is very rare. You may have somatic mutation, but the vast majority, 75%, will have a deficiency in mismatch repair because of hypermethylation of MLH1. So that's something that you have to keep in mind very closely. How to test for this? Immunohistochemistry is recognized, it's cheap, it's easy, it's available everywhere. You need the sample size can be small. However, if this is not completely clear, then you have to go for PCR or NGS. This is what the guidelines are recommended in this respect. Now, going to the data, as you know, last year we had 3 trials. All the 3 trials had the same goal, to show the contribution of immune checkpoint inhibitors together with chemotherapy, carboplatin and paclitaxel, in patients with advanced and recurrent endometrial cancer. So the goal was the same, but there were differences, of course, according to the 3 different trials. Some of the differences are outlined here. First of all, as you can see, the percentage of DMMR in the RUBY and ATTEND is very similar, is about 22-23%. There is difference in the composition of the population. I mean, in RUBY, there were more newly diagnosed, stage 3 and stage 4, and less recurrent disease compared to the ATTEND trial, for instance. If you look at the carcinosarcoma, this was included in ATTEND and RUBY, but not in the GI 018. Non-endometrial histology was more frequent in RUBY and ATTEND. The time since completion of chemo, prior chemo, was 6 months in ATTEND and RUBY and 12 months in the energy study. Follow-up is very different. Actually, 24 months for RUBY and 28 months for ATTEND. Now we heard that this meeting results from RUBY with a much longer follow-up, 37 months, and is kind of short in the energy study. Duration of treatment is different, and also the statistical design is very different because RUBY and ATTEND were very similar, and they had as a primary endpoint both the PFS and the OS with a hierarchical study design, while in the GI 018, there were 2 populations that were tested separately, basically, the DMMR and the PMMR, and the endpoint was only PFS, no OS included. For the DMMR population, it's incredible to see how consistent is the benefit. If you add whatever you want, dostarlimab, pembro, or atezo, you can achieve a great improvement in progression-free survival. This is quite clear, so consistent across these three trials. Now, ATTEND the Ruby also had as an endpoint the PFS in the all-comer population. And again, both trials met this primary endpoint and demonstrated superiority in progression-free survival in the overall population with the addition of ICI. Now, if we can then go to the pMMR population, then the problems start, because I want just to remind that only the GI018 study had power to examine the pMMR population. For the other two trials, this was just a pre-specified subgroup analysis, but it's not analytical. And in the GI018, there was an improvement, and this was updated at this meeting, actually. And for the other two, in the ATTEND, we didn't see any benefit at all in the proficient population. And in the Ruby, there was a slight improvement also in the pMMR population. Going to overall survival, which again was a primary endpoint for Ruby and ATTEND, you see this is the updated overall survival presented at this meeting on Saturday. For the DMMR, you have an incredible improvement in OS, but also now the trial met the primary endpoint of overall survival in the all-comer population. This is the second interim analysis, but is positive, with a hazard ratio 0.69, so this is now the final analysis of overall survival for this study, so there is an improvement. Now, here is the ATTEND trial. Again, you see in the DMMR population incredible overall survival advantage with this flattening of the curves, very important. They, you know, when they respond, they go on forever. But in the overall population, we had a trend which is not yet statistically significant because we didn't reach the maturity of the data yet. So the question here, and it was one of the questions before, will chemotherapy plus ICIs replace chemotherapy alone, also in the pMMR population, and how to select the good pMMR and the bad DMMR? In the Energy GI018, a subgroup analysis showed that patients with a DMMR for methylation had the same advantage compared to the mutation of the DMMR. But the problem is to identify those patients who do not benefit. And here there are some of the differences across the trials and why they show different results in the pMMR population, and how to select the good pMMR. There are some suggestions for PD-L1, P53, you have heard it before, and so on. I just want to show you in the ATTEND trial, there was this incredible situation for the Asian versus white population, where this is the all-comers, and you see a benefit clearly in the white population, but not in the Asian population, which actually go into different directions, so that's important. And also for the PD-L1, you see a possible trend for a benefit in this direction. And here you see the pMMR population I presented at ESGO last week. So for the Asian, you have a detrimental effect in the pMMR population with atezo, while in the non-Asian, you have a possible benefit. So that's something that we have to understand why. I don't know, we look carefully, we could not understand why. The P53 we mentioned already, this could be something to look at, but small number, I think we need confirmation with a bigger trial. And so the other question is, will ICI alone replace chemotherapy in the frontline setting? And we have these three trials. Keynote C93 completed the accrual. Domenica is still ongoing. Unfortunately, the LEAP-001 is negative. And this was reported last week. And these are basically, this is the summary of the conclusion. So unfortunately, did not meet the primary endpoint. Not even non-inferiority could be demonstrated. And so unfortunately, this is a negative study. Finally, this is my conclusion. So I think the incorporation of ICIs into the first-line treatment provided a substantial PFS improvement in patients with advanced recurrent endometrial cancer, particularly those exhibiting mismatch repair deficiency. One trial, Ruby, showed benefit in overall survival now, but still many open questions remain. Will ICI replace chemotherapy in the frontline setting? How to identify patients with no responding DMMR? What about the PMMR MSS? Can we do better? And so immunotherapy has transformed the endometrial cancer treatment landscape and changed the first-line standard of care of patients with advanced and metastatic endometrial cancer. Thank you.
Thank you so much, Dr. Colombo. That was a master class. We're going to move on into some of the answers, hopefully, to Dr. Colombo's questions, looking at novel investigational strategies for newly diagnosed endometrial cancer. But we'll start with our faculty questions around, the first one is going to be selinexor.
Selinexor is a fascinating agent approved in multiple myeloma and diffuse large B-cell lymphoma, and now in endometrial cancer, we're seeing excellent activity in p53 wild-type tumors. Our consultants are interested to hear your thoughts about this agent and its future, and the expected tolerability issues, as commented on by Dr. Solani.
When you have p53, it's a tumor suppressor gene. So when you don't have p53, the tumors can grow kind of unvetted, right? So they can grow limitlessly. When you have selinexor, it actually brings p53 back into the nucleus. And so it kind of reactivates that apoptosis pathway. And so it makes a lot of biologic sense to kind of, because p53 gets driven out of the nucleus. Selinexor is currently being explored in a phase 3 clinical trial looking at the p53 wild type.
What kind of efficacy signal came out of the selinexor?
It was really impressive. When they looked at the p53 wild type group, which is a pre-specified analytic endpoint, they saw a hazard ratio that was favorable. And I want to say it was about 0.4, which is really impressive. And then they just showed long-term data at ASCO last year. And we saw a difference of about 27 months versus like 7 months in the p53 wild type subgroups.
What about toxicity? In myeloma, they adjusted the dose and schedule.
I think there's a couple differences, though, and I do respect that. And this is why I have a lot of caution on using these new drugs. But in myeloma, it's often after patients have seen multiple lines of therapy. And here it may be in patients as they've seen earlier lines of therapy. The dosing structure is also a little bit different. The discontinuation rate was nothing that was alarming. It's a different patient profile. It's earlier lines of therapy. Their bone marrow may not be as fatigued as in those later lines of therapy that we see in the hematologic malignancies.
So here we have the questions. Maybe, I don't know, we want to start with Dr. Slomovitz. What about the differential outcomes between p53 wild type and p53 mutant?
Thanks for that. I think Ritu hit it spot on. I think that in the p53 wild type, the p53 works. It's not mutated. So if you're inhibiting the export out of the nucleus, you're allowing it to do its job as a tumor suppressor gene. So in that respect, I think maybe it's a little bit of a too simplistic view of it, but I think that's probably a
Sometimes simplicity is a good thing. What about tolerability? Dr. Powell, do you have any thoughts about that?
Yeah, I think Dr. Solani pointed out good points as far as how pre-treated the patient was. I think in the follow-up trial, being slightly lower dose seems to be probably more fitting for the patients. Hopefully the dosing strategy now is a little better worked out.
But as you know, we are running now a phase 3 study in patients with p53 wild type. We are using a lower dose now, 60, so probably this will be better tolerated.
Yeah. Okay.
Yeah.
That's
I'm not worried about the lower dose because actually, if you look at the Siendo trial, the mean dose was 60.
Yeah.
So actually, all we're doing now in the export trial was we're starting at 60, and we're also mandating antiemetics, which should help with the tolerability.
Great points all. All right, let's go to the next question, which is around homologous recombination repair status, as well as PD-L1 as potential biomarkers for response from Dr. Bacchus.
While PARP inhibitors have revolutionized the management of ovarian cancers, these agents are also being studied in endometrial cancer, particularly in combination with chemotherapy and immunotherapy, and our consultants are interested in your views on these emerging data and whether particular subsets of patients might benefit more.
We saw at ESMO, and Dr. Westin has recently published that also, the DUO-E study with durvalumab and olaparib in recurrent endometrial cancer and maintenance therapy. We're going to have a new paper come out there. What the split is, how the responses for the patients with mismatch repair deficient versus proficient cancer. And also in GY018, we're going to see PD-L1, if that is a possible biomarker of response. So I'm personally really curious to see how those trials are going to compare. Is that really a biomarker, PD-L1 that we saw in DUO-E, or we're going to see a similar result in 018? Should we start ordering PD-L1 testing again for patients with recurrent endometrial cancer? And if so, which test should we order? Should we do the CPS score? Should we use a TAP score? Or is there any other scoring that we should be using?
Okay, so we're going to look at these DUO-E and Ruby data in just a second, but let's start with you, Dr. Powell. Based on the findings of these studies that were just presented, what do you see as a role for PARP inhibitors in endometrial cancer?
Yeah, I definitely think there's going to be a role. I think it's a little premature at this point to recommend it for everybody, of course. And, we saw from Ruby Part 2 that P53 mutated group seemed to be the one getting that most benefit in as far as hazard ratio on the forest plot, but really cautioning all of us, using forest plots to drive care is not a good idea at this point. So I also would like to see what it's doing for overall survival. Is there downstream bad side effects of giving PARP inhibitors? So the data is maturing. I think it's exciting. There's clearly patients that are benefiting from the addition of PARP, though.
And do you think, Dr. Colombo, that we're going to be seeing it to be predominantly in those patients with BRCA mutations or homologous recombination deficiency? Or what about another wider population?
Yeah, PARP inhibitor is a target therapy, so I think we should target to a specific population.
Yeah.
The important thing, how to identify of P53 can be one. HRD in endometrial cancer, what it is. I mean, we don't know how to determine HRD there, but for sure, I think it's not for all. I mean, in my mind, I think we have to identify better the population who can really benefit from the use of PARP inhibitors. But it's an interesting approach for sure, yeah.
Yeah, I mean, I think you and I have had this conversation. You design these trials with what you know, and then more data come out as the trials are developing. And so you wish you had kind of more granular data than what you were able to do when you plan. Let's look at some of the survey results. And just as a reminder, we're showing you just a snapshot of some of the survey results, but you have full access to the entire faculty survey on your iPad. So first, based on the results of the phase 3 DUO-E trial, evaluating durva with chemo, followed by potential durva olaparib maintenance, would you like to be able to use the strategy in your practice? So interesting, it's all over the place. So I definitely, I'll start with myself, having given this this group of agents quite a bit. The patients with microsatellite stable disease, there's something there. I agree with my colleagues. Trying to tease out exactly who it is good. But for now, I don't have something I'm more excited about in microsatellite stable disease. And so if I get access to these drugs with the compendium or FDA approval, I will use them. And then I think for everyone else, you have some granularity, maybe for BRCA or HRR mutations, or if we know the HRD status, which, as Dr. Colombo just said, we don't really have a great way to do that yet in endometrial cancer, but hopefully we will be able to clarify. And then we have a few that are not yet ready to make the jump, and that's okay. There's no judgment up here on the stage. Let's talk about selinexor. So this was what the group was asked about in selinexor for P53 wild type. And you can see that in general, people agreed there's an improvement in progression-free survival in the maintenance setting. Exciting, want to see the results of the phase 3 data. And hopefully this will get done quite quickly. Tolerability. So you heard that was a question from Dr. Solani, and I think our panel handled it very well. And I think most of us agree that discontinuation rates are low for this agent, and as long as you are kind of aggressive in managing, these are manageable toxicities, and these are things that we can address. We know how to do these things. These are similar for what we're seeing in PARP inhibitors. We have a minute or two. I would love, have you all given selinexor? Has everyone here participate? Yeah? So what we do is a lot of prophylactic antiemetics. Any other tips and tricks that you guys have utilized?
It's spot on. I think that we've learned a lot from the Siendo trial and moving forward with the export trial, which is open and accruing. I have a patient on, and it helps. doing
Yeah.
the aggressive mitigation strategies with the mandated antiemetics helps a lot.
Yeah, and I think, depending on kind of the way that the translational results all shake out amongst these the triplet trials with PARP inhibitors and IO versus something simple like selinexor, doing one thing, it'll be really important to kind of tease out those molecular data and determine if that's how we potentially want to make our decisions. Okay. Great conversation. All right, so let's get into the next group. I'm going to summarize a lot of the data that we kind of asked a lot of questions about these trials. I'm going to go through the data in detail for you today around novel investigational strategies for newly diagnosed endometrial cancer. And I think you already heard from Dr. Colombo. I'm really proud of us, right? We used to treat everybody the same, and we really are working now to take the molecular classification that was developed through the Cancer Genome Atlas and really drive how we treat patients in a more molecularly based fashion. So we're making so much progress as we kind of understand the difference in these tumors and how we treat them. And the bottom line is we know checkpoint inhibitors improve progression-free survival in patients with advanced and recurrent endometrial cancer, especially in that population that has the specific biomarker, the mismatch repair deficient. But we are seeing some activity, and both Dr. Colombo and Dr. Powell have both mentioned this, it's just not as much. And so we can still do better in that microsatellite stable population. So we wanted to explore the addition of another drug to this patient population. So the DUO-E study was a randomized phase 3 study. It was an advanced and recurrent endometrial cancer, any histology, including carcinosarcoma, allowed no prior chemo unless it was given in the adjuvant setting, and it had been at least 12 months since they had received that agent. They were randomized 1 to 1 to 1. All patients received chemotherapy. Arm 2, the durva arm, received durva in addition to chemotherapy, and arm 3 did as well. If the patients were found to have no evidence of progression at the completion of the chemotherapy phase, they were then continued on to maintenance. The control arm had durva and olaparib maintenance. The durva arm received durva with olaparib placebo, and then the durva olaparib arm received both of those active agents. Endpoints were dual primary endpoints of progression-free survival, comparing the durva arm to control, as well as the durva olaparib arm to control. And there was a primary analytic endpoint of overall survival as well. I'm going to talk about what's already been published, but I will tell you that there are 2 abstracts later today that are going to be discussing a lot of the critical secondary endpoints, including response to therapy, duration of response, and PFS2 and the like. So first, let's talk about the characteristics of this population. I'll only highlight a few small things. One is that similar to what you saw with the ATTEND trial, we had a high proportion of patients that were enrolled in Asia and a moderate, I would say, proportion of underrepresented minorities. We did better with this trial. We can always do better, okay, as far as the enrollment for that population. We were about half and half newly diagnosed and recurrent, although the majority of the newly diagnosed were stage 4. You can see the bulk of patients had endometrioid, but we did have a good representation of serous and carcinosarcoma. So the bottom line, DUO-E met its primary endpoint. It improved progression-free survival in the intent to treat population. Both durva versus control and durva olaparib versus control improved or reduced the risk of progression. You saw a hazard ratio of 0.71 for the durva arm and a hazard ratio of 0.55 for the durva olaparib arm. And with a non-analytic comparator endpoint, we did see a hazard ratio of 0.78 comparing the durva olaparib to the durva arm. And I just want to call your attention to the 18-month landmark analysis where we saw a doubling in the proportion of patients who were progression-free at 18 months, with 46% in the durva olaparib arm versus 21%. Now, we did tease out by a number of biomarkers. These are planned subset analyses based on mismatch repair deficiency, and you can see that on the left with the mismatch repair deficient, both of the control or the interventional arms did improve and reduce the risk of progression as opposed to control. Not much difference between the two of them, though. You don't need to do any kind of fancy statistician stuff to see that those two curves lay on top of each other. However, in the other side with the mismatch repair proficient, you can see that that's really where we started to see a separation of the curves based on the combination with the durva olaparib arm, reducing the risk of progression over 43%. Now, interestingly, we also looked at PD-L1, and this was based on the TAP mechanism of testing. You can see about 70% of patients had PD-L1 positive disease, and this did appear to be a discriminator for us for results. You can see on the left where patients were PD-L1 positive, that really replicates what we saw in the intent to treat and the mismatch repair proficient group with durvalumab reducing the risk of progression almost 60% in that PD-L1 positive, a hazard ratio of 0.42, and the durva arm having a hazard ratio of 0.63. Well, conversely, in the PD-L1 negative, we didn't see that separation of the curves. So it is very interesting to us, and we could talk at length about this around how that wasn't what we saw in GY018 that was just presented by Dr. Eskander a few days ago, where that didn't seem to be a discriminator. So we'll really need to understand if that's the mechanism of how we're testing PD-L1 or if there's something different about the agents. The safety, let me see if I have lines. Yeah, in general, most people are gonna have an adverse event on this. The grade 3 adverse events are higher in the durvalumab arm, but that's primarily driven by anemia and neutropenia, which can be managed quite well. We always wanna look at MDS and AML, especially with our concerns around overall survival for this patient population. We've had no incidents of AML or MDS as yet, and we are at about 18 months of follow-up. Discontinuation rates were similar. If you look on the left, that's including patients on chemo and maintenance. You can see that in general, there's a slight increase in discontinuation across the two interventional arms, but really we don't see as high as we might expect when we're giving this many agents. When you look at the maintenance phase, only 14% are gonna discontinue the combination of durva and olaparib, and we would anticipate that would get better as people get more comfortable with these combination agents. We do need to use liberal dose interruption and reduction as needed. And this is just a little bit more granular detail around the adverse event profile. You can see, again, primarily driven by the bone marrow tox that we see with chemotherapy, as well as with olaparib, lots of anemia, fatigue, nausea, and constipation. Really not too much of some of the other worrisome side effects. Now, these are data that were hot off the press presented by Dr. Mirza and colleagues around Ruby 2. So just as a reminder, this was an arm of the Ruby study that was that allowed for comparison of the combination of chemotherapy with dostarlimab and niraparib given in the maintenance setting as compared to chemotherapy alone. Similar population that you already heard about previously, and the primary endpoint was progression-free survival, both overall and in the mismatch repair proficient group. These are the baseline characteristics directly from Dr. Mirza's study, very similar to the populations we've already noted, but I will note they did an awesome job enrolling underrepresented minorities in this trial, and they'd be congratulated. High proportion of patients with endometrioid, but a moderate amount with serous as well. And they did meet their primary endpoint. So this is in the intent to treat overall population. We saw an improvement of 40% reduction in the risk of progression with the addition of the PARP inhibitor niraparib to dostarlimab as opposed to placebo alone. And this was continued in that mismatch repair proficient and microsatellite stable group, so still a 40% reduction. So this does seem that there is a signal here for activity of the addition of PARP to immunotherapy. And I agree with my colleagues that teasing out exactly who these patients are that are benefiting, that are driving the difference in the curves is important, but this is a potentially practice-changing option. Now, they did look at mismatch repair deficient as well in a pre-specified exploratory analysis, and you can see an improvement and reduction in the risk of progression in that population as well. But we don't have the comparison of dostarlimab here alone as we did with DUO-E. The safety summary, very consistent. Most patients do have some type of adverse event, but calling attention, I didn't do that, sorry. Calling attention to now we're flying ahead. Bear with me, people. This thing is not wanting to listen to me. There you go. Discontinuation rates, which were fairly low, 13% as compared to 36%. And this is just the review of the adverse events that patients experienced in more than 25%. You can see high proportion of nausea, fatigue, anemia. We are missing thrombocytopenia, which I think many of us would expect to see with the niraparib, but that's likely because it was separated out into low platelet count and thrombocytopenia in the ECRF. And then finally, I don't even need to give this slide because Dr. Solani did such a great job explaining to you guys why selinexor works. But these exportin inhibitors, basically, nuclear exportin, it's going to basically take the tumor suppressors across into the nucleus. And when we block it, we keep those tumor suppressors where they want to be, helping our cells to stop the bad actions of tumors. And so, as expected, the SIENDO study was done in an all-comers population. And again, no judgment. We put these studies together when we think we know what we're doing. We learn more molecularly, we learn more translationally, and then we kind of have to go back sometimes and we wish we designed it a little bit different. But in this all-comers study, patients were randomized to selinexor versus placebo, and the primary endpoint was progression-free survival. And it did show a difference in that intent to treat population, slight, with a reduction in the risk of progression of about 30%. However, where we really saw the benefit was when we looked at the P53 wild type population. That was where we saw a very significant improvement in progression-free survival. But I say significant because it's significant to look at, but there wasn't clinical or statistical significance put here. And that's why we now are moving forward with the kind of tailored question that we learned from that SIENDO study, and that's going to be answered in the XPORT-EC trial, which is randomizing patients with P53 wild-type endometrial cancer to either selinexor or placebo. So very excited to see the results of that study as we move forward. And so thank you all so much for your attention. I think we're very excited about where we are in endometrial cancer and where we have to go. And I think we're ready to move on to what do we do with these patients if they have progressive disease after their upfront therapy. So that will be module 3. We're going to start just like we always do with videos, and Dr. Slomovitz will take it home with all the data. So first, our consulting faculty question, looking at managing toxicity with lenvatinib and pembrolizumab, which is obviously one of our critical combination options for this population.
Our neighbor down the road here in Miami, Dr. Slomovitz, is about to present some interesting data related to second-line treatment, including the use of lenvatinib pembrolizumab, an important strategy, but now being reconsidered in light of the new data with chemo and IOs in the first-line metastatic setting. We also know that the lenvatinib-pembro combination poses considerable challenges in terms of treatment toxicity, and our consulting faculty is interested in how you minimize treatment-related complications. Here's Dr. Solani's approach.
I know there's been some creative or clever dosing strategies that have been undertaken, and I'm wondering if the experts here think that there are some particular starting dosing or if there's some strategies of kind of managing side effects that you start early on in the process when you're treating a patient with lenvatinib pembrolizumab. I do start at the recommended doses of 20 and 200 milligrams. I'm very quick to reduce the dosing if the patient has toxicities. I do also have them report their blood pressures directly to me through the, MyChart portal, which sometimes can be overwhelming, but it is a good tool. And then I also often give them a prescription for blood pressure medication. I tell them to hold it, but if we want to start it, then it's actually really easy to start, and make sure I have partnered with their PCP who also will, help manage issues as they come along.
So yeah, I'd really be interested to hear everyone's thoughts on this. What are your preemptive strategies? I think we've been giving this combination of agents for a couple of years now and hopefully have perfected our abilities. Dr. Colombo?
Yeah, I know that there is a question about the dose, but I want to comment now. I think I'm probably the only one saying that I'm starting with 20. And that's because a pharmacologist told me that it's extremely important to reach the steady state very quickly to have activity with lenvatinib. And for that reason, we are using 20 at the beginning, and then we tend to decrease if there is toxicity. So just to comment on the dose. But to prevent this, I think it's very important the education of the medical staff, of the nurses, and the patient and the relatives. They have to be prepared. They have to know what's going to happen. We have to monitor very closely the patients every week with, all the blood pressure and of course, to try to understand immediately when a side effect is coming and to intervene very soon. That's, I think, is crucial in order to avoid then the very severe toxicity that you can see with this combination. But in terms of dose, I start with 20.
Any other thoughts around strategies, preventative strategies?
Yeah, I've learned so much from you because I started as 20 as well.
So do I.
Or I'm smart. I always listen to smart women from Italy. No, yeah, I definitely started 20 because what I'm worried about is if I don't start at 20, and if it doesn't work and they don't have side effects, did I not do a good thing for the patient and expose them to potential risks? So I do start at 20. As far as managing side effects, I start with the management as soon as I decide I'm going to give it to them. I tell them to help work with them to manage their blood pressure control, see their primary care doctor, see whatever we can do in anticipation of starting lenvatinib, knowing that we may see some bumps there. But yeah, it's something that we watch closely. And I think the point here, the multidisciplinary team works out tremendously to help with us.
Yeah, I think you'll see on the next slide, I'm the one outlier. I typically write them for 18, have them start at 14 for a few days, and then work up. And because it's very rare that you start, I mean, when you start at 20, sometimes people get really sick real quick. And I just have been pushed by that to think, a week or so at a slightly lower dose, I doubt it's going to cause a problem, but it's certainly safer for my team to start at slightly lower dose. And again, tailoring it to the patient. Some of these patients are well fit and 20 is great, but
Okay.
a purist in me would say 20 every day, but it's
He's
hard.
panicking. Do you guys hear? He's like, I can't believe I'm the only one. All right, so now we're going to go on to treatment of patients with an isolated recurrence on or after treatment with immunotherapy.
With the increasing use of checkpoint inhibitors in endometrial cancer, Dr. Bacchus is curious about what could become a common scenario of a patient with long-term disease control who then develops an escape oligometastatic lesion or lesions.
In his IO population, I think it's interesting that sometimes we see great control or patients with no evidence of disease, everything melts away, and then something else pops up in a random spot. The first question is, do you take this patient off immunotherapy? And how do you manage the patient with an isolated nodal recurrence or isolated lung recurrence, or maybe even an isolated peritoneal recurrence? In the second scenario, say she did chemotherapy with immunotherapy for recurrent disease, and then 6 months after completing her 2 years of immunotherapy maintenance, and she ended with no evidence of disease, something new pops up and she has an isolated recurrence. Say again, she has an isolated lung or peritoneal recurrence. How do you handle that? And then what do you do afterwards? Do you restart chemotherapy again? Do you start immunotherapy again? Or even if it's not resectable, what do you do with that patient that has a recurrence?
Okay, yeah, so I think this is a very compelling, we're seeing this now in our patient populations, both that have been treated with single agent checkpoint or those that are getting this as part of their maintenance strategy. Dr. Powell, do you want to start? What would you do in this population?
I really think there's a great role for, one, making sure it's cancer. That is key.
Good.
Could it be sarcoidosis?
Excellent
Could
point.
it be granulomatous change? Certainly we see that on checkpoint. So I do think a biopsy is pretty critical here. And then oligometastatic disease, I think a great role to embrace our radiation oncologist, and SBRT has been wonderful with this. If they're tolerating their checkpoint, and especially if they had disease in a lot of other places that all went away, I would probably keep that patient on checkpoint. Now, if you were just treating the same area and you clearly progressed in the one known measurable area, well, I think we could probably say maybe moving on to something different. But I've had a lot of luck keeping them on checkpoint and using SBRT.
Well, and there are some intriguing trials that are looking at this where they're combining SBRT and radiotherapy with immunotherapy to try to augment both the radiation and augment actually the immunotherapy.
Yeah, actually, this concept is very popular now in ovarian cancer during PARP inhibitors, but can apply also here, I think, because the rationale behind is the heterogeneity of the tumor. So you may have sites which respond very well to the therapy, and other sites, they develop kind of resistance. So it makes sense to get rid of these sites and to continue with an effective treatment on the other sites.
Right.
So that's the rationale behind this. And I must say that it makes sense, particularly in ovarian cancer on PARP inhibitor, but it makes sense also here. And actually, we have very good data in this respect. Some of them, of course, will develop more generalized recurrence. Some of them will go okay. So I think it's worth trying at least. And we use radiotherapy a lot, stereotaxic radiotherapy for this isolated metastasis.
Yeah, great points. Okay, let's look at some of the conversations that were had in the survey. And again, you've got your full records in your iPad. So second-line treatment for a patient with metastatic endometrial cancer with disease progression on platinum and platinum and paclitaxel. And we see, wow, look at that.
Yeah, you're the only one.
Good. I mean, when does that ever happen? Everybody agrees. So lenvatinib and pembro, and then for MSI high, maybe single agent. Brian, why?
That was a typo.
Okay.
Yeah.
Okay, good. I was going to call him out, but he's like, no. He knew. Okay.
Yeah,
so that's a pretty good. Let's see if we get any more controversial ones next. I'm trying to move forward. Oh, okay. All right. So second line treatment for. Oh my God, I'm struggling here. Okay. Second line treatment for a patient with metastatic endometrial cancer, disease progression on paclitaxel, platinum, anti-PD-1 or anti-PD-L1 antibody. So let's see. Here we got a little bit more So we got a couple, there's some len-pem. I think, this is an important question, right? We don't know a lot about immune after immune and specifically the combination of len. What do you guys think about that? I think a few of you put that.
Yeah, so Peter Rose and colleagues wrote up their experience. There's a publication out of Ohio State as well, looking at this checkpoint after checkpoint, especially with lenvatinib pembrolizumab. There was some responses. I think, it's dealer's choice, and it's really an area of unmet need now that we have.
Yeah, and I think some patients like the idea of adding one thing to what they've already been tolerating well and seeing how that goes before moving on to a completely different regimen. But I think chemotherapy and bevacizumab is also definitely an agreement. And then, Dr. Slani brought up a point that I don't think that many of us thought of actually re-challenging with platinum-based therapy, which would also be a very reasonable option. And then here we go. This is the one we all wanted to see. Wow. So, Dr. Colombo, you thought you were the outlier, but in fact, you have convinced us all. No, I think a lot of us do. And I had the same kind of theory too, like, do we need kind of that high level dose to start, a bolus dose to kind of get somebody up to that steady state of lenvatinib and then, reduce? I don't know the right answer. I mean, I think I liked what you said, Dr. Powell, about kind of starting a little bit lower and adding up. I think we're all just doing our best because we want our patients to be able to stay on a very active regimen. And I think that's the bottom line. So I'm going to turn it over to Dr. Slomovitz, who's going to review all the data for our current options.
Thank you so much, Shannon. This has really been a lot of fun. So it's an honor for me to be here and to really diving deep in this conversation. So, the world's changing, and we talked about the world's changing. Even this meeting with all the latest data, I can't even list all the trials. So that's going to change what we're doing in the second and third line, and we're going to need to catch up with that. But just to start, let's see how we got to where we are in the first line. Was driven by the data that we saw, the activity in the second line, and it's the activity in the second line which really said IO is an option for all women with endometrial cancer. Because it's not only this single agent data, which we'll go through. This is the Garnett data. First looking at dividing out the DMMR population, 46% response rate, PMMR population, 19% response rate. So we saw that there's a signal here, complete responders, partial responders, really saying with this asset that yes, in the DMMR MSI high population, we can go forward using dostarlimab alone. Here's specifically in the endometrial population from Garnett, again, just highlighting the 46% response rate. When we look at the median PFS, 6 months, median overall survival was not reached. Again, clearly demonstrating the activity here, making it a no-brainer. If those patients, and these patients are going to be fewer now with all the data, but in the second line, if they haven't yet received a checkpoint inhibitor, clearly you can give checkpoint inhibitor as a single agent in the second line. And here's the pembrolizumab data, Keynote 158. Similarly, in an MSI high population, 48% response rate. In a biomarker unselected population, 11% response rate. Again, demonstrating, to highlight the point, DMMR, MSI, one agent. Unselected biomarkers, PMMR, we needed to do a little bit more. So this is a study, Keynote 775, which was the confirmatory trial based on the initial studies worked by Vicky Macker. A prospective randomized phase 3 trial of lenvatinib pembrolizumab after platinum-based therapy for advanced endometrial cancer. This study included both PMMR patients and the DMMR patients. Primary endpoints were PFS by BICR and overall survival. Secondary endpoints are listed here. Really the landmark study showing that immunotherapy works in all patients. The standard of care arms here, doxorubicin. I always remind people, it's adriamycin, it's not liposomal doxorubicin. And there's always someone in the room who needs to be reminded of that, I think. Or weekly paclitaxel is a standard arm. And we'll talk about this, how this is a really good standard in the last slide I'll show, which was one of our future directions that we're currently working on. Lenvatinib, to remind everyone, some people call it, it's a pan-TKI, dirty TKI. It has a lot of good effects, and that adds to the great benefit that we see in helping turn those cold tumors hot when we're adding on about the synergistic effect or the additive effect with immunotherapy. So here's some of the data. This is the pMMR population from 775. In the PFS, we could see that the Len-Pem median PFS was 6.6 versus 3.8, hazard ratio of 0.60 or 40% reduction in recurrence. All-comer population, similarly, a hazard ratio of 0.56, again demonstrating the effect here as far as progression-free survival goes, and is also overall survival, 17.4 months in the pMMR population versus 12 months, hazard ratio of 0.68% or 32% reduction, and in all comers, 18.3 months versus 11.4 months, 15.2 versus 10.5. Now, what we don't know, and I'm not sure if we're ever going to do a direct comparison, we probably won't, is in those DMMR patients, do we need lenvatinib, or would lenvatinib help out the effect of the single-agent immunotherapy? I said it was a typo before, and it was a typo, but maybe there are some patients, I'm not sure, but maybe there are some that would benefit from Len-Pem, even with the DMMR MSI high tumors. And then Vicky Macker, this was a longer-term outcome, overall survival data from Len-Pem versus chemotherapy with extended follow-up of over 16 months, basically showing that it still held true to form in the pMMR population. Overall survival had a 30% reduction in those patients who were treated with Len-Pem, and in the all-comers population, it was also 35% reduction. The elephant in the room, what about the side effects? What do we need to help manage these side effects? We know that the most frequent related treatment of associated adverse events with pembrolizumab, hypertension 64%, hypothyroidism 57%, diarrhea 54%, nausea, decreased appetite. And we'll go through this a little bit more closely. Dose interruptions, you could see here 58% dose interruptions with lenvatinib, discontinuation of 31% with lenvatinib, 19% with pembro, 14% with both in these trials. This is a slide that we often have on. It really just shows in those patients treated, what are the most common adverse events and the timing till the first. And we could see here, I don't want to spend too much time on this, but the AEs associated with IO, you sort of get used to seeing them in the clinic. You sort of know when they occur, the order they occur, and when you're surprised if you see something, or when it's sort of what you'd expect to see, and and that'll help us manage it as well. Key points in the toxicity management: increase awareness about the toxicities with our patients, and I'll get into this a little bit more specifically. Working on prevention and prehabilitation when possible. As I sort of alluded to, get your blood pressure under control before you start the medicine in order to help it if you do see those bumps while in the medicine. Management of the toxicities as early as possible, and increase and ameliorate the adherence to the treatment. This slide is a little bit, and I think you all have these slides. This slide's a little bit too busy to go through, but I really just want to highlight on two important areas. Here's the early detection of effective management of hypertension. Lenvatinib should be withheld in any instance where a participant is imminent at risk to develop a hypertensive crisis or is uncontrolled hypertension. For those patients already on antihypertensive medicines, the dose of the current regimen may be increased, or I don't do this, but consult with the primary care doctor about adding in a different agent. And when the blood pressures continue to be uncontrolled with the antihypertensive agents, then you may have to withhold or stop the lenvatinib altogether. Similarly, I think diarrhea is a side effect that we try to figure out, because the diarrhea can be associated with both agents. Now, we know that immune-mediated diarrhea and colitis are among the most common immune-related adverse events. In these cases, when I'm suspecting this, I really get the GI folks on board and doing an endoscopic evaluation to help to identify those patients at high risk to see if they need to be on steroid management. Versus a diarrhea associated with lenvatinib can be ameliorated with dose reductions, occasionally dose interruptions, but loperamide and diet modifications. that's what we had as far as second-line management with IO. I quickly want to go through some of the newer things that we're looking at outside the scope of this talk, is we're not even talking about the hormones and the biomarkers, the mTORs and the CDK4/6s. So there's opportunities there. Here's one class that I know Shannon's been working very closely with, the WEE1 inhibitors. There's some, here's 3 earlier trials showing some activity with the WEE1 inhibitors, and we're moving this forward within GOG Partners. Shannon's leading this, I think, a really important trial, GOG 3065, the Teton trial, looking at ZN-C3004, a single-agent study looking at a WEE1 inhibitor in those patients with uterine serous carcinomas in the recurrent setting, to seeing if we can mimic some of the activity and making it more manageable that we've seen in some of the other WEE1 trials. The ADCs, I know Matt's going to talk about the ADC for HER2. ADCs, though, ADCs for HER2, I'm sorry. Here's a TROP2 ADC, the sacituzumab ADC, which was previously reported. Dr. Santin, sitting in the front table here, had some really promising data that was reported at ASCO in 2023, making it overall response rate here of 33%, making it a good option to further investigate. And here in the public domain is the MK2870 asset. We're opening this now. It's open in the US actually already, GOG 3095. Looking at the MK2870, their TROP2 ADC versus physician's choice chemotherapy. Again, going back to the doxorubicin or weekly paclitaxel. The future's bright. There's a lot we're looking at, particularly in the post-IO setting, whether it's IO after IO, some of these new ADCs reverting back to the hormonal biomarker strategy. It's a really exciting time. So thank you for your attention. Thanks.
Great job, Dr. Slomovitz. That was such a great review. And what we're going to do is we're going to move on to the 4th module, and then we'll have some time at the end. We've got some audience questions. I hope you all, if you have more, please send them to us so you can pick the brains of these very, very smart people in front of us. So now we're going to move to HER2 targeted therapy for the management of advanced endometrial cancer. And as always, we have a video. So the video is going to really focus on the approach to HER2 testing in endometrial cancer and how to incorporate trastuzumab deruxtecan in the treatment armamentarium.
HER2 testing and anti-HER2 therapy has been a critical part of the management of breast cancer since the late 1990s, but in the recent years, we've seen the rapid expansion of the use of anti-HER therapy, particularly the ADC trastuzumab deruxtecan, into a variety of other solid tumors. Our consulting faculty is excited about this new research development and curious how the faculty on the stage is thinking about the use of these agents in their practice.
It was only 40 patients in each cohort, but the duration of response was notable kind of across all the gynecologic malignancies. And these patients were heavily pretreated for the most part. So I think it's a really, really exciting area of, advances. I would like to ask the panel, for uterine cancer specifically, we were doing HER2 testing based on the breast. The Destiny trial was using gastric testing. Are you doing both now if you're using it in frontline with carboplatin paclitaxel? So are you testing both? That's kind of a strategy you have for now and future, or have you just adopted one testing strategy and just using that moving forward?
I think everybody has been very, very impressed with what we've seen from the DESTINY-PEN-2 trial with trastuzumab deruxtecan, or TDXD, in really all of our gynecologic cancers. It's now NCCN listed, but doesn't have FDA approval yet. So do you have any hesitation in using this drug? Are you using this drug? And what should we be watching for also as we use this drug? Should we be more worried in this population about developing pneumonitis? And how should we be looking for it? And then how aggressive should we be for treatments? What do you do for cardiac monitoring with this? Because cardiomyopathy can also be a side effect with these drugs. And we know that from trastuzumab as well, the other HER2 targeting agents. But what do you do for managing this and assessing for it, either during or before trial, of course?
Okay, so we got a couple of, I think, very, very important questions here. I'll start with you, Dr. Powell, about HER2 testing. What are you doing? Are you using the gastric? Are you using the breast?
So great question, and that's just to confuse our pathologists. For our upfront study, the GY026 study, we're using the breast guidelines, and for the ADC use, obviously gastric, and so we often are having to ask them to go back in testing. And I think it's probably a good idea to do, especially if they were a 2+ or 1+ before on the breast. Sometimes you'll see differences when we apply the gastric testing. So yeah, it's confusing, and obviously we have one of the big experts in the room, Dr. Santine, as well.
You know, I think a point that we've been kind of reviewing a lot at MD Anderson is a lot of the outside panel testing, the next-gen sequencing testing, just look at amplification of HER2 as a test positive. And it's really important to make sure you get that IHC testing, that protein testing, because even in patients that might have negative for amplification, they may still qualify. And I know you're going to go through this, but they may still qualify for the agent, which is really, I think, an important thing not to miss. Yeah, go ahead, Dr. Slomovitz.
You know, I think that's a great point with the backup IHC. And as far as what tests, you know, I've been using it, and I'm really excited about the data, and it got NCCN listing prior to a publication. I like to say it works. I'm really excited about it. What tests do I use? Any report that has 2+ on it, I send in, and it gets approved. Right? Yeah. So I think as we move forward with FDA approval and regulatory strategies, yes, it matters. But at this point, there's not one company has written back and says, well, was it gastric or breast or so? And it doesn't have to be the latest biopsy. I can go back an earlier biopsy. It has it, I get it approved, because we don't know if it's 1+.
Yep.
And in the risk of doing no harm for our patients, I definitely like to give it if there, because there's not a lot of other options.
And so let me just raise, are you guys using this in HER2 positive? And do you have access to it yet, Dr. Colombo?
Unfortunately, we cannot use it in Europe, so I would love to, but only inside clinical trials. So the results are extremely compelling, so hopefully we will be able
soon.
To use it. Yeah.
And you said endometrial and ovary and cervix, yeah?
Yeah, that's, I mean, any HER2 positive. If I found a vulvar patient, I would. What about GI prophylaxis? Are you utilizing anything like that, Dr. Slomovitz, Powell?
No, that's not normal. No, I haven't had that much issues.
Yeah. We send people home with scripts for what we think they might need, right? So antiemetic, anti-motility agent, just so they have it on hand. And then if they call in with an issue, we can say, okay, take this thing. So I think that's sometimes kind of handy to send them home, but I'm not necessarily making them do that. Although I do feel like some of the patients, the nausea really is quite significant. And so having them, have the ability to have something like that is important. What about screening for interstitial lung disease? Are you routinely doing that, Dr. Powell?
Certainly clinically. As in part of their radiographic imaging as part of monitoring their cancer. I haven't gone to additional imaging beyond that at this point.
So no kind of standard imaging
just kind of their
scheduled.
every third cycle scan right now. Trying to standardize this across the practice, I think, is something we're talking about, and to understand the risk. Because the risk of pneumonitis is real, and whether that additional radiographic imaging is going to pick something up sooner, we don't know yet.
Yeah. Dr. Slomovitz, anything different? Are you doing any kind of
clinical? No. Nothing additional.
Now, what would you do with a grade 1? So if you identified a grade 1 interstitial lung disease, maybe on routine scan, asymptomatic, would you continue the agent?
Yeah. So I have a patient like this, and I sent the patient to pulmonary. I work hand in hand with the team, and they're doing aggressive pulmonary monitoring. In my open discussion, they say, well, it may work. Let me follow her for a little bit, keep it going. And she hasn't flinched yet, but if she does, then we'll make adjustments then.
I think that's a really important point. It's an important point with all of these novel agents that we use, is really having a multidisciplinary team and having some go-to people that you can kind of quote unquote share the pain with is really important, and make sure that you're not missing something. I do think that grade 1 can become very serious very quickly, so you want to make sure the patient's aware of the symptomatology that might be associated with progression of that ILD. So really important points. Did you have anything to add, Dr. Powell?
No, I think if there's consideration, certainly a dose delay is not a bad idea. Just I don't know if we need to rush into something if they have a potentially evolving process.
Great point. Okay, so we have a few of the faculty survey questions around this. So usual first-line therapy for HER2 positive metastatic disease, we see for mismatch repair deficient, a lot of chemotherapy with PD-1 and PD-L1. Mismatch repair proficient, the majority of you guys are using trastuzumab, smaller phase 2 study. versus the me believing in a phase 3. No, I'm really all over the place as far as addition of trastuzumab versus pembrolizumab, dostarlimab. I think this is really where kind of getting some of the granular translational data is going to be so very important. And now second line, HER2 positive, disease progression on paclitaxel, carboplatin, and trastuzumab. So here we see a lot of us kind of moving to IO in a patient population that's MSI high that has not yet gotten immunotherapy. And then we see trastuzumab deruxtecan certainly becoming a very positive answer for mismatch repair proficient disease. And then third line treatment, we're seeing here, this is again HER2 positive, mismatch repair proficient, had carboplatin, paclitaxel, trastuzumab, as well as lenvatinib and pembrolizumab. And now we're being asked to see what we would offer in that line. Pretty universal trastuzumab deruxtecan. I know Dr. Colombo would want to. So this is just a little bit of a difference here between our European colleagues and what they have available to them. But I know in her heart she would be utilizing that. But certainly doxorubicin, weekly paclitaxel, definitely your standard of care, second line, third line chemotherapy agents. All right. Oh, another one. Third line treatment, mismatch repair deficient, HER2 positive, has already had chemo with trastuzumab, is mismatch repair high, so actually had second line anti-PD-L1, PD-1, very consistent here too. Moving on to TDX in this population where available. So Dr. Powell, why don't you take us through the data here with HER2?
All right. Thank you so much. And we talking about HER2-directed therapy, the management of advanced endometrial cancer. Many of you know, HER2 has been around a long time, as mentioned in the videos. The testing ranges that we see for serous cancer is kind of wide ranges, and that has a lot to do with interpretation algorithms, and I'll spend a little bit of time talking about that. Dysregulation by whole exome sequencing in TCJ was about 27% of cases, and obviously HER2 needs a partner to work, and some of that is a rather complex scenario, and as we look about strategies for targeting HER2, these likely matter. It was real simple with the ASCO CAP guidelines with breast, are rather simple. 3+ is really easy, but when you're 2+, doing a KISH or a FISH type testing to reflex to see who is actually considered HER2 positive. This has evolved over time. There were earlier breast guidelines, and then now the 2018 guidelines you see here on the bottom left, showing that utilizing both the staining intensity and the location. The 2016 brought us the gastric guidelines, and I think the differences there, that basolateral or lateral type staining is important. I'll point that out on the next slide. Colorectal has some of their own guidelines. We're a little stronger intensity, but also basolateral, lateral. And when you look at your amplification, your FISH amplification, there's some somewhat unique differences among the different groups. In the Fader-Santine trial, looked at a 30% cutoff for those who are positive, and then that HER2 ratio of greater than 2 for the FISH and KISH. So what do we see under the microscope? And again, I don't claim to be a pathologist looking at these every day, but panel A is really easy. I think everybody in the room can say, yep, that's strongly intense, good pattern, greater than 30% of the cells. What about C? So C is some glands are staining, some glands aren't, and we see that in endometrial cancer. The one nice thing, if you could think about an ADC, you can get that bystander effect and hopefully having enough of the positive cells within the tumor will drive those outcomes. Now 2+, it starts to get a little trickier as you see panel B and you start to see the basolateral panel. And then D is that lack of apical membrane staining. So pathologists actually are asking a pretty big job, and I think one of the things Dr. Slomovitz mentioned, maybe test twice until a different area until you can find that 2+ biopsy, because that heterogeneity and differences in staining patterns and differences in technique can all drive that. We looked at within one of the tissue databases utilizing the 2007 breast guidelines versus 2018, and this is in endometrial cancer, KISH, the two separate KISH criteria. And actually, the in situ hybridization was the most, you found the most cases doing that. You actually found the least using NGS as you're looking for cases. So when in doubt, I think one of the KISH or FISH tests may be warranted as we look into this further. Sorry. We also know that HER2 is actually an important predictor of outcome. This is stage 1 patients with serous cancer, most of them having received carboplatin paclitaxel adjuvant therapy. And you'll see those that are HER2 positive have much worse outcome, both on a progression-free and overall survival. So twice worse outcomes when your HER2 is involved in their cancer. So we need strategies for not only advanced stage, but also early stage patients. Looking at Dr. Fader and Santin's randomized phase 2 that's been discussed, this was a rather small trial, but was really a championed by the authors to move this forward. And really you'll see in the stage 3-4 patients, newly diagnosed, where they had the most benefit, and with that overall survival benefit with a hazard ratio of 0.49, and there were groups receiving adjuvant trastuzumab, really became compendium listed, and how can we improve on that? And this is the TAPER trial. This is adding pertuzumab to the trastuzumab, looking as single agents. And again, it's not quite how we would use it, and we'll get to that, but there is a good disease control rate, so that addition of pertuzumab makes sense to do. And that's what we did for our GY026 trial. So this is currently ongoing. I think we have a little over 100 patients accrued. Carboplatin paclitaxel versus carboplatin paclitaxel with trastuzumab versus the same plus pertuzumab. And this is a subcutaneous injection form. This does involve all stages of patients, and it is a randomized phase 2 design. We may end up getting rid of one of the arms if it looks ability to do that after the early stage portion. We're really focusing on the ADCs, and we have a few different ones we can discuss with trastuzumab deruxtecan and BNT232. In the interest of time, we'll kind of cut right to what I think everybody's been talking about. This is one of the most exciting things in the past year in GYN and perhaps all cancers that contain HER2, but specifically in the endometrial cancer cohort of 40 patients. 22% of the patients had prior HER2 therapy, likely with trastuzumab. And you see the multiple lines of prior therapies, good racial admixture, and that overall response rate of 57% in the population. And that was really striking in the 3+ positive. Those 13 patients that were 3+ positive had that, nearly 85% response rate. Obviously the side effects, as mentioned, we talked a little bit about that nausea vomiting issue and the ILD pneumonitis that occurred in 10% of patients. Here are Kaplan-Meier curves for PFS and OS, and really kind of unprecedented in this line of therapy. So when they have the biomarker, we have a tool now that we can target and lead to these good outcomes. As mentioned, those side effects, about 35% of patients had grade 3 side effects, and there were 2 deaths as part of this, and that was so really that reason we had some discussion about pneumonitis. The status trial is the same looking in carcinosarcoma, one of our hardest to treat diseases. And I think this was just staggering when we saw this, that nearly every patient treated had response, as you see from the waterfall plot there, and the not only the HER2 high, but the HER2 low patients showing response. Again, that same safety signal of pneumonitis, ILD, was noted in up to 27% of patients. So reason to be cautious and reason to be looking and managing this. The BNT232 was this, Katie Moore presented this, Dr. Moore at ESGO 2023, had a cohort of HER2 expression, both high and low, for endometrial cancers, including our carcinosarcomas. This is the waterfall and spider plots as shown. 59% had prior immunotherapy, 38% prior HER2 therapy in this. And you'll note the impressive response rate of 58.8 with a disease control rate of nearly every patient, so 94% disease control. The other ADCs in development, I'll skip over that in the interest of time, and really highlighting that HER2 is an important biomarker, and I think perhaps when we talk about molecular staging of endometrial cancer, this should be part of our algorithm, and I think the PROMISE Plus should include HER2. Efficacy has been demonstrated combined with chemo with trastuzumab, but now we have a new tool in our armamentarium. We still think it's important to further investigate the trastuzumab-pertuzumab combination, but with that, I'll conclude. Thank you.
Thank you so much, Dr. Powell, and really to all our speakers. We got through such an incredible amount of material in such a short amount of time that I know the audience is so appreciative. And we do have just a few minutes for questions, and so I think I'll start with one. There's a patient that was on GY018 on the placebo arm, rapidly recurred in less than 6 months, then treated with a single agent pembrolizumab, and now no evidence of disease. How long do we continue? What do you guys think? Dr. Colombo?
Well, I would continue probably for 2 years.
2 years.
Yeah, I think that could be my choice.
She's DMMR?
I'm assuming. I don't have that data, but I would assume so based on the results.
Yeah, 2 or 3 years.
Yeah? What about you, Dr.
Yeah, I think a minimum of 1 is what I tell the patient.
Yeah.
If you've had a complete response, I'd like to follow you for at least a year, but I don't know the answer.
Yeah.
I mean, it may be that they're done. I mean, it's really hard to stop if they're tolerating it, though.
Yeah, I mean, I think it's always shared patient decision making. I think if there's still disease, it makes it a little bit easier to say, okay, well, let's stay on something, but in evidence of no evidence of disease, I would stop around 2 years as well. On that same note, what's the longest duration of PARP that investigators have used it for? Now, I know that would be specific, I guess, to those of us that have done it on trial. What do you think, Dr. Powell? What did you guys do for Ruby?
I'm sorry, for
Ruby, for PARP inhibitor and Ruby.
Oh, for PARP inhibitor Ruby, that continued for up to 3 years.
3 years, okay, yeah. And for DUO-E, actually it's continued until progression, but there's some of us that have had patients on for like 3 and 4 years, and given the recent data with PARP inhibitors, have decided to maybe hold it because of the unclear advantage, beyond that. Dr. Colombo, you look like you wanted to pipe in.
No, just to say that in the ATTEND trial, Atezo was continuing until progression, so I do have patients now 5 years on treatment.
Yeah.
And, I don't dare to stop, but probably I should, but yeah.
Oh, here's a very good question. So, Dr. Slomovitz, this is your section. Why don't we change lenvatinib to bevacizumab? Wouldn't bevacizumab be less toxic in combination with pembro?
Yeah, that's a good question. So there's actually been one study that reported out of bevacizumab with atezolizumab last year by Dr. Moore and Dr. Pha at the IGCS meeting we had in New York, and it was moderate activity. I don't think it was as good as what we've expected that we'd see with the lenvatinib. But then there's no head-to-head activity, but head-to-head it'll be easier to compare, number one, and also obviously the toxicity profiles to see if in fact they were different.
Yeah, I mean, I think they're definitely different, right? Monoclonal antibody versus an arguably quite dirty kinase inhibitor. So you may be getting some activity beyond the VEGF and from some of the other targets with lenvatinib. We don't know, but it's certainly a very compelling question. Okay, last question. Okay, Dr. Powell, is there a concern about GY026 accrual with now the advent of trastuzumab deruxtecan?
Yeah, I think that definitely a concern is people maybe holding off, but you'll see from the ADC trials that a lot of patients had previously been on this. Right. So I don't think we're probably harming them by using it. Now, it would be smarter to go right to deruxtecan, and that's hard to know. Certainly, we don't have the pneumonitis with these agents, and I think needs to be investigated further. The early stage patients, obviously, I don't think we'd be putting those on ADCs at this point, so that makes sense to continue that going.
Okay. All right, well, we've come to a close. I just want to first thank all of you for spending your lunch hour with us. I hope that you enjoyed it as much as we did. And I want to just thank my colleagues, Dr. Colombo, Dr. Slomovitz, Dr. Powell, for their awesome presentations and their great discussion. So thank you all.
Thank you, Dr. Westin.